All right, everyone. Thanks for joining. We're going to get started here. My name is Rob Messmer. I'm Sales VP and Channel Chief at CBTS. And it's my honor to kick off this presentation on improving patient outcomes with technology and innovation, really focused in the healthcare space. We've got two folks with us today that you may have heard of if you're a current client of CBTS. But Matt Douglas, who runs our sales engineering group, is with us, as well as Dustin Leak, who heads up our healthcare practice. And CBTS really has had a focus in the last 3 to 4 years on healthcare and driving IT service solutions to that space, which really starts becoming a center of excellence as we've brought more and more clients on, seen more and more use cases, and really focused on patient outcomes and helping them deliver their requirements through IT for their organization. So for today's presentation, we've got Matt, who will kick us off, tell you a little bit more about CBTS, and then hand it over to Dustin, who will talk specifically about our healthcare practice. They've asked me to ask everyone to please feel free to put questions into the Q&A area or the chat area, and then Gabby Scott will read those off. And we'll send out this presentation after the conclusion. And with that, I'm going to kick it off to Matt Douglas to give a little introduction into CBTS. Matt?
Thank you. Thanks for unmuting me there, Gabby. Yes, my name is Matt Douglas with CBTS. I'm the Senior Director of Solutions Engineering here. I may have met some of you on the phone here. Thanks for joining our presentation. Today's going to be mostly Dustin sharing some of his observations from the field in the healthcare area. I do run our sales engineering group, so my team would come in and help assist with you and your staff investigating any of our possible solutions and if they might fit. Let me give you, for some of you who don't know, let me give you a little bit of background on CBTS. We are publicly traded on the New York Stock Exchange as CBB. And where that came from was really Cincinnati Bell. Cincinnati Bell, started 140 years ago. And in fact, even a couple of years ago, we bought Hawaiian Telcom. So about half of our business, if you would, is to be the phone company in a particular geographic region. Deliver fiber, deliver mission critical services. And so that's been a big boon for us as well as we've moved into healthcare through the years, is our ability kind of growing up, being telephony and delivering mission critical services kind of part of our DNA. Now, you're talking to CBTS here on the phone, or excuse me, on the WebEx, which also goes under the Onyx brand up in Canada. And where this started was about 25 years ago or so. We started kind of as a regional VAR in the Midwest, typically selling kind of routers, switches, telephone systems, et cetera. And over that 25 years have grown quite a bit. We now are about a $1 billion a year entity, all across with services all across North America and globally as well. We've expanded quite a few of our services globally. This is a wide variety of services. We represent over 350 different manufacturers of IT equipment and services out there. In fact, one of the things you're going to hear kind of from Dustin is a big move on our part to move to services, to consulting and managed services. And in fact, today, about 50% of our business with customers is about consulting and managed services that we deliver. We've got a couple of different verticals, which healthcare, Dustin's going to talk specifically today. We also have a big vertical, of course, in the commercial segment, but a big vertical in government and education as well. So I want to just give you a quick little overview of a little bit of our history, kind of some of our focus, and I'll turn it over here to Dustin to expand more on some of the healthcare.
Thanks, Matt. All right. So, good afternoon. I'm Dustin Leak. Thanks for the nice introduction, Rob. I run our healthcare practice for CBTS, as Rob and Matt referenced. I I came to CBTS with 15 years of working in healthcare IT, both operationally and strategically. The most recent 6 years was as CTO of a large IDN in Florida. But I've got experience both in acute ambulatory, hospice, home care, wellness, insurance, children's hospitals, tertiary hospitals. And most of that experience has been, as I grew up as an engineer, mostly on the prem hardware side, but then really the last 6 years of my traditional healthcare experience was transitioning from those traditional prem-based solutions into more cloud solutions to leverage some cost savings that are included there, as well as some security improvements that can be realized through that type of cloud or hosted solution. Also have some consulting experience. I worked for a Silicon Valley startup, so I learned a lot about failing fast, what it means to be agile, and taking on acceptable level of risk in order to accomplish the organizational goals. And then most importantly, former Army veteran, or I am an Army veteran. So as Matt kind of mentioned, he talked about our history. But throughout that history, we've always taken a client-first approach through any of our products or consultations with customers. I think what's really impressive about CBTS, and quite honestly, one of the reasons that I chose to join CBTS is this client-first approach. We sit and we listen to what you have to say before we even offer our opinion or a solution or various solutions to solve your problem. So 2 years ago, when I started at CBTS, prior to that, I was a customer. I brought CBTS in to take all of our telephony endpoints and host and manage those endpoints. And over the course of that time, whether it was the engineering and architecture or planning and then ultimately deployment, one of the things that was really driven home and the sole reason for me even considering leaving traditional healthcare IT was CBTS's engineering approach. The sitting across the table, listening to the business problem, asking intelligent questions, and then coming back to me with a well thought out solution, and then modifying from that point based on new data. And then the other point I'd like to draw out on this slide is that CBTS is a HIMSS North America Diamond level member. We work with HIMSS every chance we get, whether it's just to learn from them or whether it's to actually add additional information or additional thought leadership into some of their solutions or some of the way that they approach healthcare customers. So the CBTS healthcare practice has 3 primary objectives, and they're really listed in order of how much time I spend in each area, how much time the teams spend in the areas. So first is to support and enable customer leadership. I think this is really important because when I was on the other side of the table and a CTO, strategy was really something we thought about once a year. We would do an offsite. It would take half a day. Maybe we'd have a nice team building exercise at the end of the day, but when we showed back up to work at the next morning, it was back into firefighting mode and the strategy went out the window. And I would add that strategy is often something that healthcare IT is challenged with through clinical leadership or executive leadership within the health system. We're constantly being asked, what's your plan? What is the plan? Where do we go from here? So I wanted to spend and do spend a significant amount of my time pre-COVID flying around the country, post-COVID via WebEx, but sitting down with our customer IT executives, spending time talking through their strategy, putting it on their paper and giving it back to them to say, hey, here's what I heard from you, right? Drawing on that consultative approach that I referenced earlier, but here's what I heard from you. Where did I get it wrong? Let's tweak it. Let's fix it. Let's reevaluate it every 4 months so that they are armed and do have a strategy when they're asked, what's our plan? What's our strategy? Because often in healthcare IT, the strategy is built from the bottom up versus coming from the top down. The other part of my role within supporting and enable leadership is monitoring and sharing industry trends, sharing what our other customers are doing, learning from our customers, healthcare, it's very important that we understand what are the other people doing in my industry? What are my peers doing? What am I missing? What should I be thinking about? So having those conversations and learning from each customer is very important, and being able to share that back, I think, is very valuable to the customers that we work with. Secondarily, it's about taking this consultative approach to our internal product teams. So Rob referenced that we really started our focus on healthcare 3 or 4 years ago, and that focus back then was really, how do I make sure that the products that we bring to market are important and relevant to healthcare customers as well as the other industry verticals, but what matters to healthcare versus maybe retail or manufacturing. So I spend time reviewing our products, working with our product teams, providing feedback. Sometimes it results in the addition of a feature that's important to healthcare customers and is missing. Other times it's really just about how do I talk with healthcare about this product? How do I help them understand how it's applicable all the way to patient care? Because let's be honest, really from an infrastructure standpoint or a managed service standpoint, we like to say that we improve patient outcomes, but when we do, it's not directly, it's indirectly. We do it through our partners in the IT departments who are providing tools and infrastructure that enables the nurses and the respiratory therapists and the doctors to be able to deliver care when they want to deliver it in the way that they want to deliver it. And then finally, partner relationships. So CBTS isn't going to be all things to healthcare. We're not going to write an EMR. We're not going to create a ventilator. We're not going to interface a PAC system to I don't even know whether it be radiology PACs or cardiology PACs. We're not going to get in the clinical side of it. There are plenty of people that do that, and they do it really well. But building the partner relationships, this role is really to identify partners that allow us to bring a complete solution to the customer. The example I like to use here is, look, if I can sell you the hardware components and some software components or the communication components to a telemedicine solution, the first question you're going to ask me is, well, is there a virtual waiting room? Can patients do education while they're in the waiting room? Or how do I monitor whether or not they did the patient education following the visit? And so if I can't provide a complete solution as CBTS, then I've really failed you. I've left you kind of hanging. So this third part is me looking at partners like an Amwell or looking at partners like a Medigate to really wrap a complete solution and bring it to you directly. So this is what I like to call our NASCAR slide. These are some of our healthcare customers across North America. We'll get into the services that each of them consume on the next slide, but really just wanted to give you the feel that we're not just a Cincinnati company. We're not just, if you're in the Northeast, we're not just a New York company. We're truly a North American company. We've got Alberta Health Services in Canada. We've got a lot of health systems in the Cincinnati area, Indiana, New York, Kentucky, Boston. It's just a small kind of smattering of who our healthcare customers are, and all the way down to Florida as well. Some of our Oklahoma ones haven't made the slide yet, so I apologize to them. So this is what I was referencing here. I call this the pretty slide, and I can't take credit for it. Marketing kind of took my ideas and made it look consumable. But the goal here is for this to be, if there's one slide that you keep on your desk to know what does CBTS do within healthcare, I think this is a good representation because it maps the products to the different care environments, all the way through home care, or from the home all the way through home care. And then down the left-hand side are some of our products. We really have four main verticals that we work from within, if you want to break it down that way. We have a communications practice that does things like hosted unified, enterprise unified communications, which is a solution that is a survivable, reliable solution that is hosted and managed for telephony within healthcare systems, that allows for the communication floor to floor or building to building should you lose your connectivity back to our hosted gateway on the internet. So to NAS or SD-WAN. So we have managed SD-WAN solutions actually we were doing some pretty interesting stuff with. I'll talk about a little bit later on in the presentation. And then we get into our cloud practice, which is everything from a virtual data center that you can put your stuff in our data center to helping you migrate to the public cloud, all three flavors, whether it be Azure, AWS, or Google. We've got a great team that comes in and really takes a look at all that's involved in migrating to the cloud and helps you as an IT leader answer the question, why can't we just put everything in the cloud? We really look at it. We understand that, hey, look, there are things that are going to have to be deprecated. There are things that are going to have to stay on-prem because of reliability or access speeds or whatever it might be, to things that fit really well within a cloud, public cloud infrastructure. And then the third pillar is really around our staffing and professional services. We see a lot of healthcare systems, especially now. You know, we've got 250 some hospital systems already that have either furloughed, laid off, or just straight up cut staff overall salary. And so they're reaching out to us now saying, hey, look, I still have the same list of things that I need to get done, but I don't have the people to do it. Help me with this. So we will do try and buy. We'll do direct hire for you and recruit people for you, or we'll do your traditional professional services in that vertical. And then the final vertical that I'll mention is really around just traditional hardware, software resale. So one of the great things about CBTS is that we have managed and hosted services if you want them and you want to consume it in an OpEx model. But if you don't want that and you want the traditional prem-based solution, we have that too. And it's really whatever you determine is the right fit for your organization. We like to have both solutions because we know that we're in the middle of a transition period for healthcare between traditional prem, CapEx-based spend, transitioning into hosted, cloud, and OpEx type spend. And then the last thing that I'll mention, I forgot it in the IT staffing portion, is we have a very large application development team that does a really great job with some really big national names in terms of development around, you know, everything from a shopping cart app that you might use for a large a grocery chain to some custom integration and dashboarding for hospital systems to help determine, you know, length of stay, you know, more of the operational executive level dashboard. I'll stop there for a second and ask Gabby if there are any questions or anything that I need to answer up to this point.
No, we currently do not have any questions. You can keep going.
Awesome. Thank you. I'll take that because I'll take that as I explained it so well that there aren't any questions. So we'll move into the second part here. And this is to help kind of lay out what's available for healthcare in terms of the CARES Act. We hear a lot about the money that's available that the government is putting out there for us and for us to use. And I wanted to break it down so we really understood what was there and kind of how it would be used. So we'll break it out into two separate categories. The first is the healthcare funding. Originally, if you remember, this is $100 billion that was, I think, in phase one. And then later, $75 billion was added in phase two. This is given to the Secretary or distributed by the Secretary of Health and Human Services. And it's to reimburse healthcare providers for expenses, and I like to highlight this part, or lost revenues related to the COVID-19 pandemic. And the final point there, as I'll illustrate in a few slides later, is that it's just not enough money. I think those of us in healthcare know it's not enough money, and the lost revenues part of it is really what's going to consume that. You know, one example I'll give there is that one of our customers just in Q1 lost $300 million. So that was Q1. That wasn't even a full month of the stop to elective surgeries, or a full quarter of the stop to elective surgeries, right? So I expect that when we see Q2 numbers, they're going to be even worse, which will kind of pull on that 175 billion number. And then the second program that's outlined in the CARES Act for healthcare is the COVID-19 Telehealth program. This is $200 million distributed by the FCC. And they are primarily reimbursements that allow for telehealth equipment and services. It's pretty loose, as I'll kind of explain in the next slide here. but it's pretty loose what you can do with it. So we're seeing some of our customers get really creative with it. So when we talk about the first part I mentioned, which is 175 billion for healthcare funding. So I like to break it down in these 4 categories. First, who's eligible? It's public healthcare entities, Medicaid or Medicare enrolled suppliers and providers, and other for-profit and nonprofit. So the key here is if you are a LLC, if you're a sub S corp, an S corp, incorporated, you're not eligible. There, aside from a couple that are specified by HHS, you're not eligible for any of that money. So the way that it works are that eligible entities spend their own money up front and then request reimbursement from the government. So imagine anybody that has an expense account with their company or an expense statement. We go spend money on our credit card, and then at the end of the month or the end of the period, we turn it in, and then our company reimburses us for the expense. Same way for healthcare's trying to get some of the 175 billion. So an example I use here is when I was working for the IDN in Florida, I think we saw a total of 6, maybe 7 hurricanes roll through. And every single time the federal government declared a state of emergency for the state of Florida, then the state government declared a state of emergency for the state of Florida. And then that allowed us to access those emergency funds. So what we would traditionally do in the hurricane example, because there wasn't a whole lot of upfront spending that we needed to do, is we would, as an IT department, look at things like remote work licenses or devices, because we know that we're going to send a percentage of our staff home. For example, if I already had WebEx, I might use money to buy additional WebEx licenses that I needed. And just augment what I already had. The hospital system or the corporate controller would track those expenses, what they were for, how they were used during the hurricane, and then eventually, and in some cases eventually meant 2 years, but in most cases a year, the federal government through the reimbursement process would refund us the money. So when you think about the potential opportunity as a customer or as a provider, you look at it and you say, well, how can I leverage this money to help me with hardware, software, or services that the IT department will use in direct response to COVID-19? I underlined the word some there because of the potential challenge. If you're in healthcare right now, you know that we're running traditionally on between a 2 and 3% average margin, net operating margin, and that margin is made up through elective surgeries. Well, back in March, almost every single state stopped elective surgeries, which immediately put a strain on that margin for those healthcare organizations. In addition to the stop of elective surgeries, they then had to start spending on whether it was adjusting rooms so that they could treat more patients, or ordering PPE, or buying ventilators, or preparing otherwise for the surge of patients that were to come. So spending went up, revenue went down, and therefore, what I'm seeing and what I'm hearing from most of our healthcare customers, I haven't come across one yet that plans to use that 175 billion or leverage the 175 billion for IT. What they plan to do is use it to help offset the operating losses that they experience due to the elimination of elective surgeries or the hold on elective surgeries. So I don't see a lot of organizations using this pot of money due to the liquidity issues, but some may be strong. I'm seeing a couple for-profit hospitals that have been fairly strong, some for-profits that have been really, really hit hard, and a lot of nonprofits that have been hit really hard. Locally, I've heard a story about one of our peers in healthcare that's planning for a 0% margin for this year. And they're doing everything they can just to keep people employed. So the next slide here lays out the 200 million in telehealth. So I see more of our customers leveraging this component of it. And I think it's a little bit easier for most people to leverage than the 175. So when we look at who's eligible, it's a little bit longer list, but you'll see it's post-secondary educational. So university hospital type places, teaching hospitals, medical schools, community health centers, health departments, mental health centers, nonprofit hospitals, rural health clinics. And this is in addition to the rural money that's given out to rural health clinics that was given out prior to COVID-19. So this is in addition, SNFs, and then other healthcare providers. But, again, the keywords here are nonprofit and public eligible. Unfortunately, if you're an LLC, S Corp, incorporated, again, you don't qualify for this, the telehealth dollars. So how it works, a little bit different than 175 billion here is that eligible entities apply for approval via the FCC. Once approved, then they submit monthly for reimbursement. So think of it this way: we've got one customer that requested 387K, and that included everything from telemedicine licenses that in this case it was video licenses, iPads, telemetry devices, computers, screens for monitoring solutions, security cameras. So they got real creative, and rather than have the nurses go into the patient's room, each time they had to do that, they would put on PPE, they would go into the room, they would check the patient's vitals, maybe administer meds, and then they would leave the room and have to put on new PPE and kind of wash, rinse, and repeat each time. Instead, they bought security cameras that they could focus on the patient monitoring devices and that could be watched remotely. And they put nurses in front of 4 computer monitors, each with a different camera view for 4 different rooms, and they could monitor the patient remotely that way and only don PPE and go in when the patient needed their intervention. So this one's pretty creative in the way, or you can get pretty creative in the way that you use it. You can use it to offset capital costs as well as operational costs. And when you fill out the application on the FCC's website, it's pretty basic. But one of the things that they require are quotes. They want to see quotes from VARs and manufacturers and partners that show true expense of your or the true expense for your solution. They do approvals on a rolling basis, so you will find out pretty quickly whether you were approved. They're prioritizing requests from the hardest hit areas of the country, and then the last thing I'll say about it is, on their website in the FAQ, they say they don't anticipate anyone asking for or needing more than $1 million per entity. So I would encourage you to go through the process. It's not that difficult. Even if you've already spent the money on these solutions or ramping up these solutions, go ahead and see if you can get some reimbursement for it. It's not that difficult of a process. So the potential opportunity for customers here, they're specifically for technology and services associated with telehealth. That's all it says. It's that loose. So think if you need to increase bandwidth, that cost can be included. One customer wanted to buy mobile devices like iPhones to give to patients that they could check out so that they could provide telemedicine instead of having them come into the traditional ambulatory care setting for that same doctor visit. And then the other thing I think here, as I kind of mentioned in my hurricane example, is it's a good opportunity for you to offset some of the costs that you already have, right? So if you're already using Amwell, or you're already using video, or you already have some sort of telehealth implementation in place, it's a good opportunity to leverage the money to ramp up that telehealth solution to make it bigger. Some are doing that in preparation of what they think might be a second surge. Others are doing it just because COVID-19 has forever changed the way that they're going to deliver patient care, and they plan to use more telehealth to deliver that care in the future. Same challenge, right, as before. If you're suffering a liquidity issue, you can't, or you may not be able to front the cost that it takes. Now, in this case, it's monthly that you would get reimbursement. So imagine a typical solution may have some portion of capital and some of OpEx. You would submit the capital up front in month 1 for reimbursement, as well as whatever OpEx is associated with that. And then monthly, you would submit OpEx that goes on because the capital has already been reimbursed. Before I move on to the next topic here, I want to stop and see if there are any questions from the group.
Yes, so we do have a couple. So how do entities submit requests for reimbursement for both of the types of funding that you covered?
So how do institutions request for reimbursement from both?
Yeah.
So the first one is traditional, any kind of disaster or emergency funding that would come from FEMA. That's 175 billion. It would be tracked by your corporate controller or your finance and accounting department. They would roll up that list, and once the pandemic or the natural disaster is over, they submit that through their state departments for reimbursement, which gets forwarded up to the government. Now, the second one for the telehealth, you submit receipts directly to the FCC via the FCC's website. So as you get quotes and once you get approved, based on the quotes you provided, you would just submit the expenses, which are receipts tied to the original approved request via the FCC's website. They have a way for you to upload them.
Okay. With the funding from the CARES Act, does that money have to be paid back, or is that funding that helps supplement lost revenues based on a natural catastrophe?
Yeah, so no, none of the money I talked about today has to be paid back. It's
Okay.
grants.
And then one other question, would State Department of Corrections be eligible for CARES Act telehealth reimbursement?
That's a good question. I don't know that, but I think we can find the answer for you and feed it back.
Okay, perfect. Those are all of the questions for now.
All right. So we're going to move now on to the solution that I referenced earlier when I talked about we're getting creative with some of our customers and really working to help them solve real-time problems. So one of our customers, IU Health, came to us at the beginning of the pandemic and said, basically, hey, we've got these remote or these screening tents that we set up outside our hospitals, and they're great, but the problem with it is that we're restricted to our own campus or our own properties where we can run LAN connectivity or wireless connectivity into them so that we can use the electronic health record. We can look up patient history and or that we can access imaging or whatever it might be. Can you guys help us figure out a way to disconnect these things from our hospitals? So we've got some really smart engineers. Justin Rice is one of them, and his leader John Lloyd worked with IU Health and said, okay, let's figure this out. So we have a managed SD-WAN solution that I referenced earlier, and I'll show you the components that are included in this. But basically, what we did was we figured out a way that we could run and manage SD-WAN back to their data center over cellular connectivity. In turn, that allowed IU Health to deploy more than 9 of these tents throughout the city of Indianapolis to go to their patients with the care, go to their patients with the screening, so that they didn't have to travel, right? So as a hospital system in the middle of a pandemic, the last thing you want are people who are infected infecting people who aren't. And one of the easiest ways to do that is for them to enter your health system. So IU Health is really looking at it as way, how can I keep my community safer by providing these screening tents in a location that may be easier for them to access, as well as that's not associated or not associated with the physical property of the hospital system. So, I've given you one example, right, which is a screening tent. But when you look at this, it really has multiple applications. So if you look at healthcare customers, whether they're traditional or whether they're SLED, they can use these things for, as I mentioned, pandemic screening tents. The state departments of health can use these for screening events. So imagine if you could go do any type of community screening or even community vaccination in a Target parking lot or a Walmart parking lot, instead of making these people either come to a bus that travels around the city, which is one way they do it now, or they have to come to the Department of Health to get the vaccinations. And then I think the other really interesting point here are the last two around the sport venue or the concert venue. So one of the health systems I worked for was responsible for providing care to Daytona International Speedway during national race events. We would set up a pop-up tent, but they would handwrite things, and when they got back to the hospital system, they would input them, and a lot of times the data would get lost. And these are from everything from minor scrapes and falls to what I like to refer to as the drunken accidents that occur in stands and around sporting venues and concerts. But now you have a way to take the care there. You have a way to connect back to your corporate data center in the healthcare setting, and you have a way to track that data real time and even look up patient history in the event they come to you and have been a previous patient. So some of the challenges here are really what I just referenced. If you don't get customers, or if you aren't a customer who's thinking more broadly about the way to use these tents, you may see it as throwaway technology. And really, we see it, as well as IU Health and some of our other customers, as just technology they're going to use for the rest of their lives, because it's given them access to the patients where the patients are versus having the patients come to the organization. The next slide here will show you some of the components of it. You would use the tent that already exists for the healthcare facility or Department of Health. We'll ship you in 3 roto-molded boxes, a generated VeloCloud Edge device, rack-mounted UPS, cloud-managed 24-port switch, the modem that you need for cellular connectivity, access points for wireless access, and then voice over IP phones. All of it's managed. There are some additional components that you can apply to it. For example, we listed one on the bottom here that we've been getting a lot of interest in, which is the Meridian temperature verification kiosk. A lot of our customers are saying, I need a quick way to see if I need to divert a patient to a different entrance based on their temperature. And I also don't want to staff the front door or every door with nurses. I want my security guards who are already there to go, your temperature is too high, you're going to have to go in through the entrance that's just down the way, where there will be a nurse waiting for you to give you a true clinical evaluation. So we can sell these components. It's customizable. If you don't need phones, we don't have to put phones in it. If you don't want a generator, you don't have to do that. If you want to just buy the temperature verification kiosk on its own, we'll do that too. Just really, this slide is intended to show you the full gambit of what we have and how we outfit the tents that exist. So I'll pause there right now and see if there are any other questions. And then the last slide is the thank you slide. So really, any questions you have about anything we discussed, about CBTS, anything.
So we do have a couple of questions that came in. Do you have any security services that would fit into the healthcare space?
So yes, we have a lot of security services that fit into the healthcare space. And primarily they fall underneath the professional services bucket, although they've gotten big enough now that we're starting to put them in their own vertical. So every kind of, I've never seen more solutions supported, assessments provided. So if you're looking for just your standard, hey, I need a cloud readiness assessment, I need to know what my cloud security assessment looks like, configuration, professional services. So yes, a very mature security solutions team that also does a lot of work with our healthcare customers.
Okay. And then are your solutions HIPAA compliant?
Yes. So, excuse me, when we talk about the hosted enterprise unified communications, the solution that I first was introduced to with CBTS and ultimately deployed on all of my endpoints, that is HIPAA certified and HIPAA compliant, data center certified and compliant that they run through, and the solution set is certified and compliant.
Okay. In general, do you find most of your healthcare customers going all CBTS in the cloud or a hybrid model with on-prem?
So right now, I would say it's more the hybrid direction. One of the things I'll say COVID accelerated for us is that customers that weren't even that were cloud adverse, we'll say nicely, they were cloud adverse before, are now you calling us up saying, hey, this cloud thing, how do I get access to, whether it be WebEx or maybe it's, some sort of Citrix in the cloud or VDI in the cloud, if you will. So we're seeing people ramp up their appetite for cloud. And I think, if we look at it, the real reason they're doing it is because their people are running all over the place trying to figure out, how to support the COVID-19 ramp up, right? Pre-surge, the ramp up. And they don't really have time to have their people integrate into their on-prem systems. So they're looking for things that can work outside of their system and be rapidly deployed. I think that's why they're doing it during COVID. What I'll say is customers I've talked to recently don't plan to go back and have now been able to demonstrate, the cloud's not so scary as long as it's configured and secured correctly. It's not so scary for healthcare. There are a lot of healthcare customers that are already in Azure or AWS. And how do I leverage it as the appropriate prem versus cloud solution? I referenced it earlier, but we're seeing an uptick in the number of assessments that we do, the cloud readiness assessment, where I mentioned we really walk through application by application and say, is it a cloud candidate or not? And that helps them better explain what has to stay on-prem and what can be moved to cloud.
Okay. And then do you provide connection to hospital database?
Connections to a hospital's database?
Yes.
I think I need a little more information to answer that the right way.
Do you set it up? Do you set up the connection to hospital databases?
So I'll answer it the way I think it's being asked. So we have, and then jump in if I don't answer your question the way you want me to. So yes, we have a large team that does database work, a large team of database engineers, architects, professional services teams that can do database configuration work, database build work, that then our application teams can also do data lakes. They can pull information out of those databases and data lakes and data pools to generate analytics on top of that data.
Okay, and then another question, do you have any other additional information around the temperature kiosk?
We do. I think if we can take down who's asking, we can make sure we get it routed to them through the right person. But yeah, absolutely we do. We have a packet that explains it, that talks about what it is, somebody that can talk to you about pricing if you're interested in that. So absolutely, if we can get their name, or if you let us know what your name is, we'll make sure somebody gets it out to you.
Okay. And then how do you see organizations planning to work social distancing into their IT department's daily routine?
That's a really interesting question. I like that one. So I've had some really interesting conversations with our health system CTOs and directors and others. And ironically, their biggest concern is not a technical concern. So they're trying to figure out how they limit the number of people that go into a bathroom. Right. So pre-COVID days, we all work in this big cubeville, and now all of a sudden, I have to maintain social distancing everywhere within my organization, even in the bathroom. So, they've come up with some interesting solutions, like we limit the number of people in the bathroom to the number of sinks. They don't have hall monitors or bathroom monitors. Others have, locked off parts of the bathroom. Others have sign-in sheets, little signs they flip when somebody's in there versus somebody isn't. Other people are talking about, do we put tape on the floor in the cubeville like we see at the grocery stores? How do we manage social distancing? But the most common thing that people are talking about doing is still leaving a portion of their staff at home. So in the past, maybe the cubeville would be 100% full. Now they're considering whether they mark that to restaurants or other capacity limits. But if a restaurant is only able to have 25% capacity, then they only let 25% of their IT team come in. And when it goes to 50, they'll do 50. But one customer I talked to yesterday said, we're thinking about working people from home permanently. And if you want to come in the office, you can. Obviously, data center folks and others who require hands-on would need to come in, but that's really giving it consideration. So I think that's how they're planning to work social distancing in.
Okay, that seems to be all of the questions today. Rob, if you want to close us out.
Sure. Dustin, thank you so much for presenting this webcast to our customers, and Matt Douglas as well. I think Dustin, you did a good job of communicating our healthcare practice, and it's not just about the products and services that we're bringing as CBTS to the space, but it's about that consultation that we do on the front end, helping customers and prospects understand the best practices, because we get to see it from a lot of different customers and venues and applications. And last is really just the consultancy that we do on taking the business policy side of healthcare and marrying that with the technology. And those are some of the soft things that outside of the technology, our healthcare practice helps our customers implement, and we found is a reason that helps really grow our healthcare practice, because again, it's not just the technology, it's helping our customer, in this case healthcare, focus on outcomes for their patients. With that, we will be sending this slide deck out. If you have any further questions, feel free to reach out to your CBTS trusted advisor representative, and they'll be able to answer any questions, schedule time with Dustin. Both Dustin and Matt are available for more conversations and understanding your what you've got in front of you, and if CBTS would be a good fit to help you through it. With that, we thank you for joining, and we'll hopefully hear from you soon.
Thank you.